Hello everybody. Today we are going to discuss about brain trauma foundation guidelines. So regarding decompressive craniotomy, it has a level 3A evidence. Bifrontal decompressive craniotomy is not recommended to improve outcome as measured by Glasgow outcome score at 6 months post-injury in severe traumatic patient. But yes, the decompressive craniotomy has definitive role in reducing mortality and improving and reducing IC. So large frontoparietal decompressive craniotomy is recommended over small frontotemporoparietal decompressive craniotomy for reduced mortality and improved neurological outcome. Now about prophylactic hypothermia. It has level 2B evidence. It is not recommended to improve outcome in patient with diffuse injury. Now regarding hyperosmolar therapy, mannitol is effective for control of raised ICP at the doses of 0.25 to 1 gram per kg of body weight. So arterial hypotension should be avoided. Now about cerebrospinal fluid drainage. It has level 3 evidence. An EVD system zeroed at midbrain with continuous drainage of CSF may be considered to lower ICP burden more effectively than intermittent use. Now about ventilation therapy. Ventilation therapies has level 3B evidence. Prolonged prophylactic hyperventilation with PaCO2 of less than 25 mmHg is not recommended. Hyperventilation is recommended as an temporizing measure for reduction of elevated IC. So the uh, point that we need to consider is hyperventilation should be avoided during first 24 hours after injury when cerebral blood flow often is reduced critically. So if hyperventilation is used, then jugular oxygenation and the brain tissue oxygenation measurement are recommended to monitor oxygen delivery. Now regarding anesthetics, analgesic and sedative, it has level 2B evidence. Administration of barbiturate to induce burst suppression measured by EEG as a prophylaxis against the development of intracranial hypertension is not recommended. High-dose barbiturate administration is recommended to control elevated ICP, which is refractory to the maximum standard medical and surgical treatment. Hemodynamic stability is essential before and during barbiturate therapy. Although propofol is recommended for control of ICP, it is not recommended for improvement in mortality or 6-month outcome. Caution is required as high dose propofol can produce significant morbidity. Now about steroid. Steroid has level 1 evidence. The use of steroid is not recommended for improving outcome or reducing IC. In patients with severe traumatic brain injury, high-dose methylprednisolone was associated with increased mortality and is contraindicated. Now about nutrition. Nutrition, it has level, the recommendation of level A is feeding patient to attain basal caloric replacement at least by 5th day and at most by 7th day post-injury is recommended to decrease mortality. Now level 2B evidence statement is transgastric jejunal feeding is recommended to reduce the incidence of ventilator-associated pneumonia. Now about infectious prophylaxis, early tracheostomy is recommended to reduce mechanical ventilation days when overall benefit is thought to outweigh the complication associated with such a procedure. However, there is no evidence that early tracheostomy reduces mortality and the rate of nosocomial pneumonia. The use of proton pump inhibitor and oral care is not recommended to reduce ventilator associated pneumonia, and it may cause increased risk of acute respiratory distress syndrome. The antimicrobial impregnated catheter may be considered to prevent catheter related infection during external ventricular drainage. Now about DVT prophylaxis. Level 3A statement is low molecular weight heparin or low dose unfractionated heparin may be used in combination with mechanical prophylaxis. However, there is increased risk of expansion of intracranial hemorrhage. In addition to the compression stocking, Pharmacological prophylaxis may be considered if brain injury is stable and the benefit is considered to outweigh the risk of increased intracranial hemorrhage. There is insufficient evidence to support recommendations regarding preferred agent, dose, or timing of pharmacologic prophylaxis for deep vein thrombosis. Now about seizure prophylaxis. Seizure prophylaxis has a level 2A evidence. Prophylactic use of phenytoin or valproate is not recommended for preventing late post-traumatic seizure. So phenytoin is recommended to decrease the incidence of early post-traumatic seizure, that is within 7 days of injury, when overall benefit is thought to outweigh the complication associated with such a treatment. However, early post-traumatic seizure have not been associated with worse outcome. At present time, there is insufficient evidence to recommend levetiracetam compared with phenytoin regarding efficacy in preventing early post-traumatic seizure and toxicity. Now about intracranial pressure monitor. It has level 2B evidence. Management of severe traumatic brain injury patient using information from ICP monitoring is recommended to reduce in-hospital and 2-week post-injury mortality. So ICP should be monitored in all salvageable patients with traumatic brain injury with GCS score of 3 to 8 after resuscitation and abnormal CT scan. An abnormal CT scan of the head is one that reveals hematomas, contusion, swelling, herniation, and compressed basal system. So ICP monitoring is indicated in patients with severe traumatic brain injury with normal CT scan if 2 or more of the following features are noted at admission. Age more than 40 years, unilateral and bilateral motor posturing, and systolic blood pressure of less than 90. Now, cerebral perfusion pressure monitor. The statement of level 2B is management of severe traumatic brain injury patient using guideline-based recommendation for CPP monitoring is recommended to decrease 2-week mortality. Now, about advanced cerebral monitoring, jugular bulb monitoring of this oxygen saturation as a source of information for monitoring decision may be considered to reduce mortality and improve outcome at 3 and 6 months post-injury. Now about blood pressure threshold. Maintaining systolic blood pressure of more than or equal to 100 mmHg for patient 50 to 69 years old and at more than 110 mmHg or above for patient 15 to 49 or more than 70-year-old may be considered to decrease mortality and improve outcome. Now about intracranial pressure threshold. Level 2B evidence says treating ICP more than 22 mmHg is recommended because values above this are associated with increased mortality. Now about cerebral perfusion pressure threshold. The level 3B evidence says the recommended target CPP values for survival and favorable outcome is between 60 to 70 mmHg. Whether 60 or 70 mmHg's minimum optimal CPP threshold is unclear and may depend upon autoregulatory status of the patient. Now about advanced cerebral monitoring threshold. Jugular venous saturation of less than 50% may be threshold to avoid in order to reduce mortality and improve outcomes. Thank you guys.